by obesity, but it also includes healthcare professionals as well. And so we are here, as Madam Chair said, to talk about Georgia's recent decision to end their bariatric surgery benefit for state employees. This was a little troubling to us, to be honest. We have a state that just implemented a wellness program that we think very highly of, but then to turn around and actually go ahead and finally start addressing these issues among people, but then take away one of the options that's available for them for help was pretty disappointing to us. If we look at bariatric surgery, it is reserved for those who are severely obese, those who are 100 pounds or more overweight and struggle with the health complications of doing so. And it's not a procedure that is undertaken by anyone lightly. It is undertaken by people who have failed at conventional methods to lose weight. And after they receive these procedures, the data is very clear. Their health conditions go away. They no longer are diabetics. They no longer have heart disease. They no longer have the other medical conditions associated with obesity. And so all of the data shows that these procedures actually pay for themselves. So if the procedure costs between $15,000 and $20,000 up front, within 2.5 years you are recovering those costs. So the fact that the health plan chose to eliminate the benefit as part of budget cuts to me is a bit, penny wise, pound foolish. Yes, you're going to save the $3.5 million that they said in 2012 by doing so, but it's going to cost you many times that going forward. I will say Georgia is an anomaly by not having coverage. Most state employee plans have health coverage, have bariatric coverage for their employees, and we actually have a chart showing those, so if you're interested in that chart, let me know. And we do find that most major employers do as well. There's a study by a group called Mercer that looks at surveys large employers, and 75% of employers with more than 20,000 employees, which of course the state of Georgia falls under, cover this benefit as well. So in respect of time, I can talk about bariatric surgery all I want as a leader of an advocacy group, but I thought the best thing to do is actually to introduce you to someone who's had bariatric surgery and hear it from her perspective. So with that, I'll turn it over to Carla to share a little bit of her story.
Name and where you're from. And
good afternoon. My name is Carla Harrison, and I'm from Augusta, Georgia. I had gastric bypass back in 2003. At the time of my surgery, I weighed 381 pounds, and currently today I weigh 195 pounds. I do go up and down about 10 pounds like most normal people do with their weight. The goal of having the surgery is to just kind of be normal, something that we've never had. It's not to have a special diet or anything special. It's to become normal, to become like everyone else around us, to affect change in our families. For myself, having had the surgery, my family has become so much healthier along with me. I've been able to change the culture within my family. We no longer celebrate food. Being raised with Southern values, I'm sure everyone here has experienced the celebration of food, the family reunions that go on for days with eating and feasting. And someone gets a raise or has a baby or gets a new job. Great, let's go out to dinner, let's celebrate. We do celebrate still that way, and I still am included in those celebrations, but I've learned to not take those celebrations to the extreme. I've learned to incorporate exercise into a daily part of my routine. I didn't know that that was what normal, healthy people did because I didn't know that. So along with the surgery came the education and the change of life. I now exercise 4, 5, 6 times a week. I do cardio. I just had an appointment with a cardiologist last week, had a lot of tests done. My high cholesterol is gone. My high triglycerides are gone. I'm no longer pre-diabetic. I'm healthy, I'm happy, I'm functioning as a part of my family. Prior to surgery, I was the mother of 2 young girls, and I was very much on the sidelines of their life. I was the mom that did the real killer, baked goods and things for special treats and things like that because I couldn't go on the field trips. Quite frankly, I couldn't fit my butt in the seats on the school bus. It was embarrassing. It was a safety hazard. I would go and I would drag. The children would run ahead of me and I would be left behind. So I would sit on the bench and hold all the coats, and then I would never go again. Now nothing stops me. I got a call, a couple of days ago that said, hey, there's this opportunity to come share your story. Can you do it? Here I am. 10 years ago, I would not have been here. I would have found a way to hide. I wouldn't have participated in life. I would have just sat and let it go by. And today I'm very excited to have the opportunity to come and show you what a difference life can make. I don't know, Madam Chair, if you all can see this up there, but this is me prior to my surgery. I'd be happy to pass it around if you'd like to see it. It's a dramatic change. Totally, I've lost 200 pounds, and again, I fluctuate a little bit, and life does get in my way, as it would without the surgery. I take medication that causes weight gain. You gain a little, you take it back off. Because along with that surgery comes the tool, and the tool is knowledge and how to live and be more productive and happy.
Thank you. Will y'all take a couple of questions? Okay, Representative Watson.
Thank you, Madam Chairwoman. Just a quick question. When I listened in on the Appropriations Committee there last week under that was health, I was disappointed, as I'm sure you were too, about the $3.5 million that was being taken out of the budget. And to me, that felt a little short-sighted. And the thought was that it takes about 3 years or so to. The study that they did was about a 3-year study or so. What's the appropriate length of study to show that gastric bypass is cost effective? I mean, I just don't recall that. To me, it's going to be 5 years and 10 years, and you're also, you're fighting age also. But
Yeah, so interestingly, the studies show between a 2.5 and 4 year return on investment for bariatric surgery. There are actually studies that have done that have shown that. So in the case of the state health plan where they geared up for 6 months, because keep in mind, no one can just go and have bariatric surgery. You have to do 6 months of medical weight management. You have to get a psychologist appointment, all those other things. And then, so really nobody started having operations until 6 months into the process. And then they cut it off right at the point where they would start seeing their return on investment. So that was very disappointing to us as well. I think you would see, and I think most of the people on the panel understand that, obesity is a cumulative condition. Over time, the effect of your weight, your healthcare costs grow over time. And really what surgery or other obesity treatments do is reset that cost curve. So instead of angling straight up, at this point, if you have a weight reduction procedure or some kind of other intervention, it bends it down this way. Your healthcare costs still go up over time because everyone's healthcare costs get greater as they get expensive. But if you look at the difference there, it does pay for the surgeries in a relatively short period of time. And I agree, again, you're saving $3.5 million now, but it's going to cost you, 5 times that down the road on the same population.
You've got other questions? Other questions? No? Thank you very much for coming. I think there was probably there's somebody else? Oh, Representative Jones, I'm sorry.
Thank you. Madam Chair and members of the committee, I was a patient. I had this treatment in 2004, and I found it to be helpful to me. I may be a little over now, but I was much heavier at that time, and my insurance company took care of it. It wasn't much that I had to pay other than my copay when I wanted to see my different doctors, so I found it beneficiary, and I think it's a great procedure. And the doctor that did my surgery, I see that he's here, Dr. Titus Duncan, and I've seen him on TV several times, so I support this procedure and keeping this in place. Thank you.
Okay. Representative Watson again?
I'm sorry.
No, just didn't turn your light off. Thank you very much for coming. Who? Pack? Oh, Representative Pack.
Quick question. I'm not in the medical field. What type of procedures can be considered a bariatric surgery? Does that include things like lap band and things like that? Or?
It does. So we have gastric bypass, the adjustable gastric band, which is the brand name you hear is either lap band or realized band. And then the third procedure that is becoming more common is called the sleeve gastrectomy, or sometimes referred to as the gastric sleeve. But those are the 3 most common bariatric surgery procedures, and the 3 that are recognized by the society that oversees these type of procedures.
Okay. Representative Dempsey?
Yes, I just wanted to say thank you for your testimony. I participated in the study committee this summer, and I know that we face some real challenges in our state economically, but also I understand the life-changing opportunity that this brings forward, not just for physical appearance, but for true health and wellness. So I thank you for coming here today and for giving us a little more information.
Okay. Thank you very much. Do we have anybody else then, thank you, in the audience that wanted to speak on this bill or on this? No, the other doctors that are here were just here as support, right? Okay. We now have a quorum. So we will go on to our schedule, and the meeting is officially called to order. Okay. Let's go. Representative Dempsey, have you caught your breath? And let's go with House Bill 434. Apparently there was some confusion. There was another bill put on later, which is exactly the same bill as 700, but since we have 400 on the schedule, that's what we're going to take. And if this committee will remember, we passed this bill out last year as it is, and it got stuck up in rules and didn't move out and toward the end of session.
Thank you, Madam Chairman, for letting me bring it back, and I hope that we can go ahead and sort of finish it up this year. This is so very important. 434 is the number, in case you have that in front of you. The reason this is coming to us is because the National Association of Social Workers, our Georgia chapter, is requesting our support to maintain and clarify licensed clinical social workers LCSW authority to diagnose mental diseases and conditions in Georgia. The definition of diagnose is currently in the LCSW scope of practice. However, the definition has not been uniformly accepted or understood. This will assure that all parties agree on the authority to diagnose is within the scope of practice of the LCSW. Clarifying language is being submitted today for consideration. The background on this, just so you understand why we're doing it. LCSWs have been diagnosing mental diseases and disorders, as they do in 41 other states, including all states bordering Georgia, as part of their scope of practice since the passage of the social work licensing law in 1984. The practice continues for Medicare, TRICARE, and most major commercial health insurance plans. In 2005, the Department of Community Health made an interpretation of the Social Work Practice Act that no longer recognizes the authority to diagnose Medicaid clients. The Medicaid clients became the issue. The evidence of legislative intent included diagnosing as a scope of practice. Just to let you know, okay, so the history of social working supports this. All kinds of documents have been brought forward on it. The draft social work bill from 1981 used the word diagnosis. This takes us back to that original intent. The Department of Community Health, the Department of Behavioral Health and Developmental Disabilities agree that this is a very important measure to help us access the best care possible. Having personally just gone through the closure of a hospital, a mental hospital up in my region, and the changes that particularly are being seen right now in Region 1, it is so important that we help people receive a diagnosis as quickly as possible and that they be able to reach the best services that they possibly can quickly. Also, I think as we move forward, possibly in considering changes in our prison population and who is there, there will be medical needs. Not only medical, but there will also be those mental health needs that a social worker can help them diagnose and get the proper care as quickly as possible.
Okay. Questions for Representative Dempsey? Representative Reiners?
Madam Chair, at the appropriate time, I'd like to make a motion on this fine piece of legislation.
Okay. Representative Rogers?
Chair Lady Dempsey, question for my own information. Can these people now prescribe medication under this?
No, it is to determine exactly what the person that they are looking at, what the exact needs would be, but it would require a medical doctor to do
So
that.
they would go straight from, based on their information.
It's faster access through the pipeline right now that is a little bit slow at times.
So they go through this process, and then they have to go through a medical doctor for the same process.
Previously, though, the determination factor then led them to another care provider, which would then do a diagnosis. So it's
So you
it's
get
just
charged here, then you
expedites
get
it.
charged again, correct?
Well,
I
no.
don't know that.
Representative, may I,
Please,
Representative
Madam
Vincent?
Chair.
Representative Rogers, these are specially trained clinical social workers that have special training in clinical medicines and application. There's only about 1,200 of them in the state. What would happen, like in our community service centers, is if they could be used like that, they would do the initial diagnosis, and then that would allow them to start being put on Medicare, Medicaid, and then they see the physician afterwards. Without them being able to give an initial diagnosis, there's a delay in the payment schedule and getting them covered and into treatment, because the delay in seeing the psychiatrist is can be, up to a month or so.
But my question is, you get charged for this, and you get charged again, correct?
They haven't been able to be paid under the Medicaid system.
Okay.
They didn't
Thank you.
qualify.
They didn't qualify because of the diagnose. And I did inquire with DCH, and they do not see this as a problem. Dr. Shep, as we change our mental health system and how we deal with patients in the community, feels like he needs these clinical social workers to help us move patients. And I'm sure there's somebody here. Consuelo, would you like to add anything to that?
Good afternoon, Madam Chair and members of the committee. Yes, the department is definitely in favor of this legislation. Not only will it help move individuals faster through our mental health services system, but we also anticipate a reduction in cost, because Medicaid would then be able to bill at a lower level for licensed clinical social workers as opposed to a psychiatrist or someone of that caliber to make those diagnoses. So yes, the department sees a cost savings, but also greater access for individuals in need of mental health treatment and care.
Representative Rogers, did that answer your question?
Not really, but that's okay.
Well, is it about prescribing medicines?
No, it's just we go to these folks, and they do a diagnosis. Dr. Watson, you may need to help me on this.
Okay.
You go to these folks to help get them on Medicaid. They need immediate help. They still got to go see another provider, correct?
If initially is decided that they may need medication.
Okay. So he's going to have to go through the same examination that the clinical folks have had to go through, correct?
Well, Dr. Watson,
I think I understand it, and I do agree with it. The thought process is that the determination does not allow social workers to bill. That's the bottom line. So now with a diagnosis, they'll be able to bill. The reason that saves the state money is because they're paying the social worker less. They're reimbursing the social worker less than they're reimbursing the physician on that particular case. Now, so the treatment, nevertheless, this basically changes nothing except it's saving the state money. They're going to pay the social worker less. They still, to get treatment, have got to go to a physician to prescribe medicine if that's needed.
Right.
It may not be needed.
Gotcha.
Medicines may not be needed, and it's certainly going to save the state even more money from that standpoint.
Okay.
well, that's pretty close. But Representative Rogers, when the patient's sent to the physician, it's a different kind of exam. I mean, a physician would be looking at their medical history and the whole aspects of any other medical problems they had in relationship to then deciding whether they could put them on medicines and which medicines that they would choose to put them on. So it would be a different kind of exam, but at least it's sort of a first screening, since not all patients need to be put on medication.
Okay.
Right, and I think that's important to realize, and it does take a while to see psychiatrists right now, so this does bring a little expedited care to that person in need.
Gotcha.
Well, and even if they think they need medicines, they can get them into the system, and they can get them into other kind of support therapies until the physician can evaluate them for medications. They can start being seen by other professionals.
though it is interesting to note that I don't see too many psychiatrists, carrying around too many stethoscopes. So, I mean, as from a practical standpoint, the social worker is going to make the diagnosis. The psychiatrist will do the prescribing. The physician who may be the family practice physician or the internal medicine doc, who does the exam and so forth. I mean, that's certainly there. Not many psychiatrists do many physical exams, so to speak. It is usually more of a prescriptive authority.
Dr. Watson, I think in our system, they often do not see the family practitioner. We're talking in our mental health systems. It is left up to the psychiatrist also to get the medical history.
It is, but practically speaking, there's not going to be a lot of that from a psychiatric standpoint in prison health care.
So I can assume this will just speed the process, is what you're trying to do for the
It will, but
qualifications from Medicaid.
Well, and I think it's real important that not everybody does need medicine. So it may be, I think like the chairman was saying, that there are some therapies, there's some group therapies
Right.
that may be able to be put in place and started that they would not have had access to.
Okay.
Okay.
All right. Other questions for the representative? All right. Anybody else in the audience that wishes to speak on this bill? Katie, you said it was a simple little bill.
One word, two times. That's
All
it.
right.
Thank
So, what is the pleasure of the committee?
Ma-
Representative Reinders.
Thank you, Madam Chair. I make a motion to pass.
Okay, I've got a motion to pass and a second. Is there any further discussion on it? Hearing no further discussion, everybody in favor of the House passage of House Bill 434, say aye. Anyone opposed, no. Okay, looks like the ayes have it. Thank you, Representative Dempsey.
Thank you, Madam Chairman and members of the committee.
Let's see what we got next. I think we have the vice chair of our caucus here, Representative Ramsey. Let's go with you and House Bill 879. I can tell you're used to judiciary. You get to sit down. We make people stand up. It's all right.
I just had some.
Just
I just had
teasing.
several papers here, so
Okay.
So I'll do whatever the chair
Just
desires.
teasing.
Thank you, Madam Chair. I'm really pleased to be before you today and to present a bill that I think is absolutely critical for the health and well-being of children that are afflicted with the disease of diabetes in this state. It's also a very personal bill for me. Until last May, about everything I knew about diabetes was because of my dad has type 2 diabetes, adult onset diabetes. I, of course, had heard the vernacular type 1 and type 2 diabetes. I'd heard the vernacular adult onset and juvenile diabetes, but honestly, I knew very little about the disease until last May. My daughter, who was 7 at the time, who is now 8, was diagnosed with type 1 diabetes. Suffice it to say that over the last 9-10 months, we have become experts in that disease. It is a disease unlike many, and it's very unique in that it requires constant, almost every hour of everyday management. It is a disease that's manageable with proper care and proper attention, but it is something that requires literally constant attention to make sure that your blood sugar is in order. Type 1 diabetes, simply put, is your pancreas stops producing insulin, so you have to inject it artificially. My daughter, until last year, we're talking about a little girl that was scared to get a flu shot once a year and would pitch a tantrum, and now she gets 4 shots a day, every single day. 6 or 7 times a day, she pricks her own little finger and takes blood and checks her blood sugar level and reports back to mom and dad or her school nurse what her blood sugar is, and makes sure that it's in the range that the doctor told her to. she's had to learn how to do, along with my wife and I and her grandparents, who often are with our daughter, have learned how to calculate how much insulin is required based on the number of carbs she's going to eat for a given meal. She's very active. She plays basketball, she plays soccer, so we have to constantly monitor during athletic events. My wife and I have to bring 3 separate different types of drinks to every game, some with sugar, some with no sugar, so we know if the blood sugar is low, we can get some carbs into her real quick. If it's high, we've got the insulin. And it's just, I tell you all this to tell you there are thousands upon thousands upon thousands of parents all over this state that are dealing with that every single day with their children. What this bill is about is making sure that those kids that go to school every day that have to manage this disease constantly, every hour of every day, can attend school in a setting that is safe and healthy and supportive. Now, I will say from the outset, I think the very best thing we could do for in a perfect world where resources and finances were not an issue, I think the best thing we could do is have a school nurse full-time in every single school in the state of Georgia that has a diabetic child there. I think we all know, given the realities of the budget, that's just not possible right now. Now we're taking steps this year to beef up funding in that area, and I'm going to continue to be a very strong advocate, just from my own personal experience, how critical it is to have a school nurse, particularly in a setting where you have a child dealing with a condition like type 1 diabetes. So what this bill does is it's going to provide some training and some resources to help lay people that are offering support to kids that go to schools that have type 1 diabetes or type 2. There are some instances, this is not just type 1, there are some instances, particularly later in high school, where it's a very small number, but kids that age are becoming diagnosed with type 2 diabetes. But what we're mostly talking about here is type 1 diabetics. So I'm going to get into the bill. I'm going to talk a little bit about what it does, what it doesn't do, and of course would be happy to answer any questions. Just to make sure we're working off the same sub, this is a little different than the bill that I introduced. I've made a couple of changes so that we're working off a sub. Betsy, you can correct me if I'm wrong, but I believe it's LC334597S. Is that right? Okay. All right. Well, I'm going to go to Section 2. Obviously, Section 1 is just a preamble that just really kind of describes the condition and the needs of children in a school setting. Section 2, really, it has some definitions, but the main point of the first, the first half of Section 2 is a requirement that the state, in collaborating the Department of Education, the Department of Public Health, in conjunction with the Georgia Board of Nursing and the Georgia Composite Medical Board, and this is an addition I made in the substitute that I think was suggested to me by the Georgia Association of School Nurses, and I think it's critically important. I've added the school nurses as part of the group that's collaborating on this. They're the folks that are on the ground, that are managing this in a school setting to the extent that they're in a school. So they're part of that collaborative process. They're going to develop guidelines for training of school employees in the needs of students with diabetes. That sets out the guidelines, what you need to look for. These are kind of basic. If you go to Children's Healthcare of Atlanta, Scottish Rite, right now there are parents sitting in there right now going through training programs. They have just had a child diagnosed with type 1 diabetes. This is kind of the basics, what you need to know to help a child manage their diabetes in compliance with what's called their medical management plan. That's kind of the Bible for a kid with diabetes that's put together by their doctor, that sets out that child's specific needs, the child's insulin ratios, the how much insulin you need to address a certain number of carbs. You have to count your carbs every meal, what the ratio for that specific child is, additional supplementary instructions. This is what you need. This is the very basic information you need to help the kid comply with that medical management plan, and also how to deal with an emergency situation. This can be a very dangerous life and death situation. My child and other children with a diabetic, they have to carry with them all the time what's called a glucagon shot, and they give it to you, and it's in this very ominous red container, bright red container. Kind of, my wife and I have often joked it's kind of like the American nuclear button back in the 80s and 90s, because they give it to you in this bright red container. But that is and you kind of break glass in the event of an emergency, and I hope we never have to use it, but that is a shot that exists if the child goes into diabetic shock due to low blood sugar and passes out. You very often can have just minutes to save the child's life, and that's what that glucagon shot exists for. How to recognize that condition, and also how to deal with the other end of the spectrum, a very high blood sugar. So those are kind of the basics of the training program. Next, we're requiring and suggesting that there be a minimum of 2 school employees at each school attended by a student with diabetes trained in these basics. Now, I think what you will find, I will tell you in my own child's experience, and even in talking to the school nurses, I had a conversation with 8 or 9 of them for 2 hours on Monday. I've talked to parents from schools all over the state that have diabetic children. I think you'll find a lot more than just 2 that are willing to step up and help. We've got a lot of wonderful people in our public schools that are anxious to help, but we want to make sure that there's at least one person in the building at all times, particularly in schools where there's not a school nurse, that can react to a situation and can provide this support to a child. And so that's why we set the threshold at 2. I would also tell you that the model legislation and the legislation that's been enacted in many other states has a higher number than 2. I wanted to be sensitive and make sure that we were not casting a wider net than we needed to, but want to make sure and make clear that at all times there's one person in the building that can help a child navigate this disease and be able to recognize the emergency signs, most importantly. We've also provided a provision going down to line 90. Well, I'm skipping ahead. Number 4 there, we are ensuring that the school nurse or a healthcare professional designated by the school system, if there's a school nurse, we always want the school nurse to be the point guard here. My wife gives me a hard time about speaking in sport metaphors, so you'll forgive me for that. But the school nurse we want in charge of that training. We want coordinating this to the extent that there's a school nurse in that school to coordinate the training that we've asked to be provided. But we also wanted to maintain flexibility for the school systems or the schools that do not have a school nurse to bring in another healthcare professional to provide the training. I was told actually by one of the school nurses the other day that there are some schools and school systems in rural areas that bring in diabetic educators and nurses to help do kind of some school-by-school training from local hospitals. So we wanted to make sure there's flexibility to fit the needs of every type of school from a resource and size standpoint. Also, at the end there, we have provided that information is going to be provided to the school bus drivers of children with diabetics on what to look for in an emergency situation. We've got a great school bus driver, and we've communicated to him what to look for, and we think it's a good step to make sure bus drivers are at least informed that A, you have a kid on your school bus that has diabetes, and B, if there's an emergency, here's what it might look like, and here's some steps you might be able to take to address that emergency. Skipping ahead, starting on line 97, we have heard stories of children that well, actually, I'm not going to skip down to that section. Basically, what line 97 says is that parents ultimately decide that they want their child to be given this support. So I can't imagine a parent that wouldn't want school personnel trained in how to help their child, and I don't think it exists. But we've been asked the question: well, what if a kid doesn't want anybody to help them, or what if a parent doesn't want the school personnel to help? This simply says that a parent can effectively opt their child out of being given help and support at a school. Again, I've never heard of an instance of that occurring, but this contemplates that. Another change that we made in the sub, in the version you're looking at now on line 107, we've heard stories of children's classes, schools that they were going on a field trip and they just didn't know how to handle the disease, and they told the child that the child could not go on the field trip with their class. They couldn't take a trip to the state capitol with their class because they had diabetes and they were scared to have the kid on the trip with them. This simply says that if you're going to go on a field trip, well, first, during school hours, you have to have at least one person that's trained, one of these personnel on site in the building. Two, if you take the class on a field trip, if you do something during school hours off-site, you're going to have one of those people go along also if the kid's class is going. Skipping down to line 117, this is another issue that's fairly significant that we know statistically and empirically and anecdotally, talk to parents or look at the statistics, that kids deal with diabetes better the sooner they take ownership of the disease themselves. You want the child understanding their body, understanding the disease, and understanding the steps they have to take to address the disease when they feel low, or when they have a low blood sugar or a high blood sugar. And there have been instances we've heard around the country of schools that have prohibited children from self-correcting their own blood sugar, and B, allowed to possess on their persons the implements to carry that out, the blood sugar testers, the insulin, whatever it may be. This simply says that upon the written request of a parent, student's parents or guardians, and if it's authorized by the kid's medical management plan, which is a plan put together by the child's doctor, the child's allowed to do it themselves. My 7, now 8-year-old, like I said, she is thriving with this condition because very early on she's very independent. She took ownership of it. We talk to parents all the time, get similar stories from their children, and that's something we want to encourage and support as much as possible. Finally, the last important and substantive provision in the bill, we hear all the time the fear, well, if I agree to be trained, and this is a fear right now. In fact, a school personnel from, I think it was Dawson County, said this to me the other day, that this is a great thing, because right now when we talk about getting people trained, they almost will not volunteer because the first question they ask is, well, what if I mess something up? What if I'm acting in good faith, I do my best, but I mess up? Am I going to get sued? We want to make very clear that if you agree to do this, if you agree to help a child out and go through this training and offer the support that so many teachers and parents and school officials are already offering, that if you do that in good faith, and then you're not going to be liable for civil damages or subject to disciplinary action for conducting that kind of service to a child. So I think that's an important and critical piece of the bill as well. So with that, Madam Chair, that's maybe not so quick summary of the bill, but it is a summary of the bill, and I'm happy to yield for any questions from the committee.
Okay. Thank you very much. Questions from the committee? Oh, Representative Reinders.
Thank you, and thank you, Representative Ramsey, for bringing this very important piece of legislation. I have some logistical questions that I'm just trying to wrap my mind around a little bit. Let's go to, and I think it may just be cleaning up or something, but let's go to that section 4 on the 2 employees on page 3. Such training shall take place prior to the commencement of each school year or as needed when a student with diabetes is newly enrolled at a school or a student is newly diagnosed. Let me just make sure I gain this out in my mind. In Randolph County, with 3,400 total people in the community, a student comes in with diabetes, grade 3. They currently, according to this, wouldn't have to have anybody because they have no students.
Right.
The child is enrolled. How much time do they have before they have to have those 2 employees?
Well, I think it would be, I'm not sure that we want to prescribe a specific day or hour time, but I think the law would say upon enrollment you would need to have somebody trained. Now, obviously, if you don't have notice until the day they show up with a kid enrolled, it would have to occur in a reasonable period of time. But I'm not sure that we want to get into legislating
And I would hate a child not.
such specific time periods. I will tell you this, though. This is the training we're talking about is something that can occur in very, very, very short order.
I understand. I'm just trying to clean it up. I would hate for a child with unintended consequences not to be able to enroll because someone misinterpreted that as well.
Yeah.
I would hate for someone to do it, I don't
Well,
know, the second
I
week.
think in reading it, upon the enrollment, that's when the obligation would occur. So I think once you have a child in your school that's already enrolled but diagnosed, like my child was well into the school year. In fact, the school year was almost over when she was diagnosed. Or a kid comes from another jurisdiction that has diabetes. Upon that event happening, that's when the obligation to go out and seek training. I'm not sure we want to say it has to occur within 3 days or 4 days and 5 days.
Yeah, and I get that. That's the difficulty of what I'm trying to decide how a local system would make their decision. Madam Chair, a couple more, and these are small. You mentioned on line 98 in the absence of a school nurse, and I just want to make sure that I understand. We are asking for 2 employees, correct?
That's right. And
Okay,
one of which would be the school nurse.
If you have
a school nurse.
If you have
That's
it.
exactly right.
Okay, now, when I look on 105 and 106 during a field trip, you won't want to accompany there. So if my school nurse or my second person got ill the night before and didn't know all the field trips that was scheduled to the Capitol or anywhere else the next day, and so therefore they called in sick like any employee would, and then your second employee went on that field trip with them, then in essence that school would be left without anybody for the day.
Would be left without a person. You're suggesting if there's a kid with diabetes
Going on the trip.
and then there's another kid there. I would think if you have 2 diabetic children and you have that type of situation, that the school's going to have to consider those things, or the class is going to have to consider those things when planning their field trips.
I would suggest to you, with all due respect, that there's no way I know as a school nurse or the second person being trained in that who's got a field trip scheduled tomorrow and I can't call in sick.
Right, and the alternative is this: is you tell the kid you can't go on the field trip with us.
Yeah, I don't want to do that. But how do we do that, Madam Chair? I'd hate to have a school.
I think what you're going to find, Chairman Reinders, which has been the experience in all the other states that have done this, is you're going to have more than 2 that are going to step up and be trained. I think we put 2 as a bare minimum, but I think because of those type of situations that could arise, a field trip or a field day, or a situation where those 2 people are out, I think you're going to find more than just those 2 that are willing to do it. But I didn't want to put a requirement any greater than I thought was necessary. But I think you'll find that schools with these type of children there, you're going to have more than 2.
And Madam Chair, if I may, and this will be the last point. And again, one size doesn't fit all. We mentioned the little bitty rural school system, and you had mentioned in your comments, what was it, Katie, the primary care physician and the management plan. In a more poor area, we've got so many children who don't even have a primary care physician. They go in the emergency room. They don't have a management plan. But I'm wondering if we had some of those bigger high schools, just thinking this out in my mind, with 2,000 students at Lowndes Middle School or some big school, you might have, I don't know, 4 or 5 kids with diabetes. And I would just hate for one of them to be on a field trip and the other call in sick and the rest are not covered.
Well, I will tell you. I'll tell you this. Right, this bill will not in any way change the number of diabetic children that we have sitting in our schools right now.
Yeah, in a bigger system, I just think it could be more that's uncovered.
And it's not going to change the number of school nurses we have in our school.
Right.
What it is a recognition that we want as many people. We want a systematic, research-based, comprehensively developed training protocol. And B, we want to get some support into these schools. Hopefully more than 2 will agree to step up and be trained. I think it's exactly what you find. I had a nurse in Glenn County tell me, school nurse in Glenn County said she had 15 or 20 people that in her little school that were one of her little schools that were willing to do this. In my experience, my daughter's teacher, parapros, they've all wanted to step up and gain knowledge, and so they can support the kid. And I think you're going to find that you're going to have more than the bare minimum from the wonderful people that are working in our schools all over the state.
Thank you, Madam Chair, and thank you, Representative Ramsey.
Okay, Representative Harden.
Thank you, Madam Chair, and thank you, Chairman Ramsey, for bringing this bill. Diabetes is either the first or second most expensive disease that we have in our healthcare system, and the lack of education is one of the reasons that it is so expensive and the reason that people's quality of life deteriorates. So this is a great bill.
Thank you, sir.
And I think if we start young enough and teach our people how to manage this disease, it'll be a major savings for the system as well as increasing their quality of life. I do have one question, and it's not a medical question, it's a lawyer question. On line 124 where you, under F, where you say that nobody basically involved will be subject to civil or disciplinary action as a result of the activities authorized or required by this code section, but then, like lawyers, when such acts are committed as an ordinary, reasonably prudent physician, nurse, local school system, state chartered school, special school, or private school would have acted under the same or similar circumstances. Is that going to create some problems? Are we going to have lawsuits coming out of this because you say, oh, well, they didn't act like they should have acted?
I think this actually is a giant leap forward over what we currently have, where there is no standard whatsoever, and if where there is no liability protection. This is meant to provide, and I'll tell you, the ordinarily reasonably prudent person standard is one that's very, I'm not going to say well-defined in the law, but there's certainly plenty of case law to give us guidance. It is meant to provide people protection from liability as long as they act as a reasonably prudent person would. They are held harmless from liability, whereas under the current law, if one of these people, these wonderful people that are raising their hands and agreeing to help children all over the state right now, if a mistake's made, even if a mistake's not made and a child's just hurt because of an act of God or a good faith, just something that happens with their condition, there is no liability hold harmless, and that they could potentially be opened up for lawsuits. So I think that the purpose of this is to provide protection to those people, recognizing there's plenty of people out there right now that are helping children that have this condition. This will make sure they have some protection from legal liability in the event something happens to a child and they were acting in good faith.
All right, so I guess then ordinarily reasonably prudent is defined in law.
Well, there is reams of case law. There's various standards in the law that we apply. Negligence and intentional action. Reasonably prudent person is kind of the lowest, about the lowest bar to clear. It's one that there's tons of case law about it. It's a very well-defined standard from a case law standpoint anyway, among trial lawyers and among people that do that for a living.
Okay, thank you. That's still, and you're saying there are tons of case law on it, kind of concerns me even more. But
I will tell you that I will tell you this. This is in terms of protecting the people that are doing this. This is a huge leap forward from right now having zero liability protection right now under the current law to now being having a hold harmless from liability. So.
Okay, thank you.
Representative Harden, it was sort of like the thing on the concussion bill and the training for that, and trying to get people to step forward. Representative Howard.
Thank you, Madam Chair, and Chairman Ramsey. I just wanted to say that this is personal to me as well. I have a daughter that's 34 years old now, but she was diagnosed at the age of 8 as well, and she's grown now. We've got our first grandbaby by her and all of the things that come along with having a family. And all of the things that you have described is we experienced. And there was, although the school system was not as strapped as we are now, there was a lot of support around the system, so I commend you for bringing this bill forward. The thing that we found, and the question that really comes to my mind, is the training part. What I found out is that in watching, even though I was in the house, I learned, I went to all of the diabetic trainings and the glucose injections and all of the above, the pills. Experience really was a key to how to respond to the high or the low, and knowing when the person was high or low. How much training will the persons that will volunteer to be trained, how much training will they get?
Well, I think the training program will be developed by these various entities that we've tasked with doing it. I think it will be up to them, but I envision, I'm not sure how the training program worked for you and your wife when your daughter was diagnosed, but my wife and I went through a couple of hour kind of the basics of how to deal with, how to carry out the medical management plan, how to figure the insulin doses, and that was a component of it. And the other component was the signs of a diabetic emergency, a high or a low, and what to do about it. So I think the specifics are to be developed. But again, I would just reiterate, and listen. There is no question that the preference would be, in a perfect world, that we have an experienced healthcare professional, i.e., a school nurse,
right,
sitting full time in every school with a child, where there's a child that's dealing with this disease. But as you and I know, that's not a reality right now. So recognizing that we've got diabetic children sitting all over the state in classrooms today, this is an opportunity and an effort to provide some more education and some more comprehensive education to the folks that are agreeing to help those children navigate the disease. So what we've put in the bill is kind of the basics. Here are the basics you need to know. You need to know, and you can read the list, but I'm not telling you anything you don't know. You've been dealing with this disease for a long time as a father. But these are the basics, and we've asked these entities, the school nurses, the Georgia Board of Nursing, the Georgia Composite Medical Board, the Department of Education, the Department of Public Health, to develop that training program, and I think that will be developed and put in place. Hopefully, well, we've got it before August 1st next year, so it's in place for school next year.
Yeah. Well, I commend you for bringing this forward, and no bill is a perfect bill, and I think it's a great start, because before this, I don't know if there was anything out there. So thank you for bringing it in. At the time, Madam Chair, for me, it being personal to me, I would like to make a motion to.
I think I had somebody else that wanted to make a motion for it to pass, but
Okay.
we're not at this time. Okay.
Thank you, Madam Chairwoman. I really do not have any questions. I compliment Representative Ramsey, and I will certainly defer to the gentleman. It sounds like that's personal for you to make a motion. I'll be happy to second that
Okay, thank you.
at the appropriate time.
Thank you. Representative Jurgensen.
Thank you, Madam Chair. Representative Ramsey, thank you for bringing this to us. I know this is a very important issue. I do have one particular question. I would assume that once these guidelines are written, then the responsibility of the training and the time of the training would then fall to the individual schools to implement that and put that into their timed budget or whatever it might be. But specifically, I noticed that in several places we also have private schools listed in here, and since obviously they don't receive state funding, how do we reconcile that?
Well, and I appreciate the gentleman for raising the question. We've had this, Representative Jurgensen and I had this conversation offline. I've had this conversation with numerous members. I've also had the conversation with my friends and the folks that are working with me from the American Diabetes Association. And it's a fair question. I've worked with Legislative Council, and I sat down and looked at what mandates do we as a state put on private schools in code, because I wanted to see how this would fit. And this would be, admittedly one of the most specific mandates we've ever put on a private school. The kind of mandates we have now are pretty general. You have to have 180 days of school, or you have to comply with the state minimum days of attendance standard. If you have a building where you operate a private school, it has to comply with the safety and health standards, the relevant state and local building codes, things like that. And to the extent that it is a concern, and I'm very sympathetic to the concern, I think it might be a better step at this point that we consider, and I've had Legislative Council draft an amendment that would accomplish it, particularly in light of the fact that many private schools are very, 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 very small. Allow private schools to opt into this rather than do it in the form of a mandate. I think many, if not most, probably, if they have a diabetic child, probably would opt into it, because what it would get them is A, all of these training resources in the program that's being developed, and B, if you agree to engage in this training process and comply with the code section, you get the liability protection that comes with it. So I would consider it a friendly amendment. I think it's probably the right step given the questions that I've received from members in this body, that we consider making it for private schools not a mandate, but rather I want these resources available to private schools. If a private school wants to avail themselves of this training protocol and they want to engage in this process, I want it available to them, but allow private schools to opt in rather than mandating it. I think that'd be a prudent step, and one that I would support the gentleman if he wanted to offer it as an amendment.
Thank you, Representative. As you know, my children do attend a private school, and we have a school nurse on site. But like you said, I know there's a lot of small schools that are homeschools that are people that are homeschooled, kids that are homeschooled that get together and meet on a regular basis. I think the opt-in approach is a great suggestion, and I'm glad that you're friendly to that. So, Madam Chair, at the proper time, I'd like to offer that amendment.
Okay. Representative Ramsey, I have one online. We'll ask the questions from. Oh, Representative Dobbs.
Thank you, Madam Chairman. I'm sorry I'm late, but I did read the bill beforehand, and I was just going to ask, what do you predict is the cost of your bill to the state?
I don't, other than the time it's going to take to develop the training, which I don't think is much. We've got the American Diabetes Association that has offered. There's kind of model training. There's numerous dozens of states that have put similar provisions on the books, and they have kind of a model set of resources and training that they've offered free of charge to the state, and will agree to help in that regard. I don't think there's any cost other than the time it takes to sit down and the hours it's going to take between now and August 1st to pull those resources together and put the state's kind of the collaborative stamp of approval together. But I don't think there's any cost. We're not requiring the schools to have on site the implements to carry it out. I mean, the parents are responsible for providing the insulin and providing the snacks for the child. That we send a little bag of snacks with our diabetic child to school every day. If her blood sugar hits 60, she needs 6 crackers. Things like that. That's currently is the responsibility of the parent, and it's going to continue to be to provide the implements to carry all the management of the disease out.
Thank you.
Yes, ma'am.
Okay. Representative Ramsey, I have one question here on line 60. You're involving 3 different groups, and I have great respect for the Georgia Board of Nursing, but this doesn't seem to be anything that has to do with the functions of a nurse. I mean, they're not changing anything like that. And I wonder if getting 3 boards, knowing the workload the Board of Nursing has, I wonder if you would not make that August deadline. I mean, would there be any reason why it couldn't be worked out? Well,
Chairman, my main concern is that we have it. I would really like to have it online for the beginning of school next year, and that's why I was shooting for August 1st. I don't know if you're suggesting that we remove the Georgia Board of Nursing. I don't know the interplay between the Georgia Board of Nursing and the Georgia Association of School Nurses. The chairman knows better that. So if the school nurses kind of work as a
well, they work under their nursing, you know, I mean, they work under your nursing license, and there's only so much they can do under their license.
I would totally defer to your expertise on that. If you think that that we don't need the Board of Nursing involved in this, that is your area of expertise and your bailiwick. I think it is important that we have the Georgia Association of School Nurses at the table. But if in fact, they're probably the better, because they're working in a school setting every day.
Well, I'm right, and more involved with it, not in the licensure or deciding what registered nurses can do or can't do.
Right.
I would make that suggestion. My jokes have not gone over well today, but I've decided you can definitely tell that you're either Southern or a lawyer, and how long it takes us. That one got a little bit of better thing. Okay, what I would like for you to do, because we have a lot of people that want to talk about this bill, and I'm sure somebody's from the school nurses and will tell me what they think about being able to develop these. Would you please step out of the room with Representative Ramsey and Representative Jurgensen, if y'all, and see if you could, while we let them testify, if you could.
I think it's already done, Madam Chair.
About
the private school.
No, but I mean, Representative Reinders had questions.
Oh, sure.
And even Representative Fullerton suggested maybe that you say not 2 people, but 2 people in the school nurses, and maybe there could be something that would keep, I mean, I think there's real concern about a child not being able to go on a field trip. Maybe there could be something with a parental permission that they could go, or something, if you would just talk about it. Okay, and so we are going to suspend with this until they have a chance to talk about that. Where's Representative Reinders? Did he leave? Oh, will you step out and talk about it, please? Did you change your mind, Representative Reinders? No. No. Yeah, right. That's why I have you as a vice chair. Okay, so while we're suspended on that one for just a minute and see if they can work out some of the things on that one, let's go to House Bill 845, and that would be Representative Watson. Oh, wait a minute. Sorry. Representative Watson, wait a minute. I'm sorry. Let me get people that want to talk about the bill. It's a late day and it's been a long one. Okay, let's see. Jason Rooks. I apologize. And thank you for everybody for waiting. Health meetings tend to run long.
Thank you, Madam Chair. My name is Jason Rooks, representing the Georgia trial lawyers today. As this committee well knows, we have concerns when there is immunity in legislation, and we're pleased to come here today and compliment the bill sponsor for striking that balance between holding people accountable and recognizing the need to provide these services to children in schools. We have members across the state who contacted us to strongly support the bill, and we're happy to do so.
Oh, it's so nice when the lawyers are on the positive side of the way. Thank you,
Thank
Jason. You. Okay. Elisa Holder. Elisa Holder. And tell us who you, and give us your name, and and tell us who you are with.
Yes, I'm Elisa Holder. I am the parent of a type 1 diabetes child in Fayette County Schools, and I'm from Fayetteville, Georgia. I would like to thank the members of this House committee today for your time to discuss this important health concern facing children with diabetes who attend schools in Georgia. You've heard some technical information from Representative Ramsey today. My purpose is to relay to you some first-hand accounts that myself and other parents have in connection to this chronic disease that's a part of our everyday lives. I invited some other families to join me today. I know their inability to come underscores the reasons why we need this bill. One is Scott. He's a single working father. His wife died 8 years ago from brain cancer. It's hard for him to take time off of work to go to school and help with his child. Joy is a single mother. She has 6 children. She teaches in a private school of children with special needs, if you're familiar with the Joseph Sands School in Fayetteville. and her child is at a separate school. So she would have to leave special needs children that she's in care of to go and take care of her child. So again, it makes it very difficult for her as a parent. Amy is a homemaker. She's at home with young children. Gathering them up and running to the school for an emergency situation is not really very easy to do either. Dana is the parent of the most recently diagnosed child in my elementary school nearby. Her child was diagnosed a couple weeks ago. It's the second child in her family. She has a 13-year-old daughter that was diagnosed 10 years ago. And so she couldn't be here today because they're still adjusting insulins, and she has to be able to run to the school and help when something doesn't go like you thought it was going to go. And Tina operates a home daycare center, so she would have to have somebody take care of all the other children in order for her to go up to the school. So these are some of the things that we as parents are facing in trying to help the schools take care of our child. Diabetes is not new, as the representative on the back row here, I'm sorry I didn't catch your name.
Okay, you did.
Said, but so one of the reasons that we have the situations we have now, the representative here said his child was diagnosed many years ago, is we have a lot of new technology, and that technology requires us to make change. We can monitor blood sugars regularly. We can give fast-acting insulin along with slow-acting insulin, and it doesn't perform the same each time you do it. If there was a PE that day was more rigorous, the blood sugar could drop low. If it was raining, they couldn't go outside, blood sugar is going to go higher because of inactivity. So there's many variables that create change, and so you can't just say this is what we're doing A, B, and C, and it be the same result every day. There's inherent risk of with low blood sugars. And I'm trying to amend what I'm saying based on time here, so give me a moment. I would like to emphasize that for me as a parent, the most important part was that the school nurse is the preferred person in the school setting to provide care for our children. In Fayette County, we're fortunate because in our school system, we have a nurse in every school. This is not the case in many Georgia counties. However, even with a nurse on staff, and this is why we need additional trained personnel, there are times that nurse is absent, they're on that furlough, or they're assisting another student who is, and they're not available. If you haven't been in a school clinic, you don't understand that we have children in wheelchairs that have to have assistance with toileting. We have kids that are on vents and ports for chemotherapy. And so if they are taking care of that child or feeding them with a feeding tube, they're not available for the low blood sugar that just happened with the diabetic child. What would you do if you received a call that your child's blood glucose level is at a life-threatening 54, the school nurse is out, and no one knows what to do, and you're an hour and 15 minutes away across Atlanta at rush hour traffic? I've gotten that phone call. And to add to that frightening situation, I gave them instructions by phone. They had written protocol, and they did not follow it. It wasn't because they were uncaring. These are wonderful school staff. They are untrained. And so there's, the other option would be to dial 911, and then you're tying up emergency personnel when it could easily have been handled by giving them a juice box, waiting 15 minutes, retesting their blood sugar, and giving them another juice box or glucose tablets if they needed it. The other thing, one thing that's addressed in the bill
that finished.
Okay, that wasn't discussed is to have the same opportunities, other educational opportunities for the child, that they carry their supplies with them. If they have to leave the classroom, I know my daughter's a middle school student. She doesn't want to leave and miss instruction. So if in some schools, the children are required to leave the room, test their blood sugar somewhere else, and come back. So that's a very important aspect of the bill, and I appreciate that being in there. Let's see. I just want to share a few statistics, just right quick, just real small, I promise. But this to give you an example. The American Diabetes Association would say that there is 1 out of 500 students, if you gather 500 students together, that have type 1 diabetes. At the elementary school near me, there are 2 out of 581, double the standard. At the middle school, there are 5 out of 815. At the high school, there's 11 out of 1,548. And in talking about the private school, there's a private school nearby. It's 200 students. They have 3 children with diabetes. They have 2 trained personnel. So these schools are just very close together, but they represent 3 out of 400 instead of 3 out of 500 ratio instead of 1 out of 500. Anyway, I thank you for your time, and I appreciate your support of this bill.
Thank you for coming. Sorry to have to rush you
That's
a little
okay.
bit. Brittany Freeman.
Thank you, Madam Chair and members of the committee. I am Brittany Freeman. I'm the Advocacy Director for Georgia for the American Diabetes Association. We are in full support of this legislation and appreciate Representative Ramsey for bringing it forward. I am pretty sure that after all the information you've heard, anything else that I have to add will be a little redundant, so I won't take up your time. I do have written testimony if you're interested, but I can also answer any questions. I just wanted to make sure you guys knew I was here. But thank you very much.
Thank you. Do we have we have a representative of school nurses here? Okay, if you'll keep it brief and tell us who you are. And
my name is Courtney Dorsett. I'm originally from Mississippi, but we moved here last year in July. Started in Clayton County. They didn't have a school nurse, and we relocated to Cobb. What ended up happening is Christian wears a pump. He's 7 now. He was 5 when he was diagnosed. Briefly, I just want to say we have experienced the nurses, all the nurses, the Cobb County nurse, Ann Coyle, Miss Sandy, and the school nurse all absent at the same time. Initially, when we met at the beginning of the year for Christian to attend the school, they said he couldn't come because he wore a pump and it was an intradermal device. Well, I begged to differ. And I kept fighting with him about it, and they said, well, they called the school board, and they decided that he could attend the school. Briefly, he ended up, the sugars dropping to 30, and I was maybe like 30 minutes away. They treated him, and his blood sugar went up. They treated him not what they were supposed to treat him, and his blood sugar went to 412. We went to the emergency room because he started clotting. His blood pressure was so high. His blood sugar stayed high for about 4 hours. And Christian was sent to the emergency room with me along with him, and his blood pressure was so high, and that's the reason why he was clotting. I'm the one set aside to do the training with the pump with them because I am a registered nurse, but I would like to add that it is no cost, as the representative was saying earlier, for the education. And like I said, the ASP people, the guys who are doing the sports with him, the teacher, those are the people that initially, whenever you start a child in school, should be the people who set aside, because it took additional a week for him to start school, because it was a delay because, they were aware that they had a child coming with the insulin pump, and after, we went back and forth about him going to the school because the school had a nurse. They finally decided, yes, we're going to let him come. And I explained to them that the pump was more easy to manage than the insulin. So I would like to add that there has been times where there's no nurses on board, but now that they know Christian and know that Christian is able, as he's took ownership of his disease, because I've taught him since he's 5 how to manage his diabetes, then they see now that we know him, he knows the signs and symptoms, he knows when his eyes are getting blurry, what's going on with his body, so he's able to say, hey, I feel like my sugar is low, and he's able to say, I need to check my sugar, I need a snack, I need a juice. So in the absence of those nurses, those people that set aside are very important, because they can also say, hey, this child, let me get this child a juice, or hey, his blood sugar's high. They call me always, and I do the triage sometimes over the phone, and I'm a hospice nurse, so I can go across traffic to get him sometimes, but sometimes I'm not able to.
So you're in favor of the bill?
I am in favor of the bill totally 100%.
Okay, thank you.
And Christian is 7, and he could have got up here to talk just as good, if not better, than me about it.
Well, if they need help passing the bill in the Senate, Representative Ramsey can run you down and have Christian.
Yes, thank you.
Be sure and bring him to see me if he gets him back up when it comes to the Senate. Do we have anybody from School Nurses Association? Kathleen? Okay, but about the question that I asked, about the fact that there would be 3 different boards do you feel like you need the Board of Nursing to come up with the rules from the Georgia Nursing Association working with the Composite Medical Board? With the Composite Medical Board. I just want to make sure I was around. Representative Watson.
Do we need the composite state board of medical examiners too? I mean, is that something school nurses could handle alone, or do you? I'm just trying to make it simple.
Well, I know, as simple
Right.
as possible to get it through. The only thing is because they're going to be working with the physicians. Okay. Where's Representative Ramsey? Are you ready to go? Did you get it?
I think we talked about the concerns. I don't want to speak for Representative Reinders or Representative Clark or Representative Fullerton, but I think the one thing that we do agree on is Representative Jurgensen's amendment, and I'll defer to Representative Reinders his assessment of what we came up with. But I think there's a comfort level the way the bill is. I think Representative Fullerton raises a very good point about potentially raising the number of trained personnel. I tend to think the more the better, but I also, in setting it at 2, am sensitive to the fact that we don't want, I think we have a very different set of schools in this state, from the rural to the suburban to the urban, so that provides some flexibility. And I think ultimately the main provision in the bill, the most important provision in the bill, is that we have at least one person on site every day that is trained. And I think ultimately what you're going to find is many more people than 2 step up to be trained. That's been my experience, and that's most parents' experience, that these folks that are working in these schools every day care deeply about these children and want to get educated and want to help the kid and be supportive. So I think that's an issue that will kind of work itself out in practice.
Okay, Representative Reinders. Oh, well, I was just finding your response to this. Are you?
You know, the hard part is trying to come up with the right language to, and I think we were comfortable. I think there were some concerns about, well, do we up it? And if we do that, we have the unintended consequences on the very small rural areas that may not have any child with diabetes, Madam Chair, and they come in and then all of a sudden they enroll and we go, now go out and find 3. So I think that what we kind of agreed on outside was just kind of leave it alone, and it may be something that has to be revisited. But I thought that was kind of the consensus outside, Madam Chair. The school trips is, I'm going to be honest with you, I'd love to put on line 108 after the code section, where is it, school nurse, at least one trained in each site available and during field trips. I'd love to put under 108, comma, unless absent, but that kind of waters it. I do think that it could very well happen where you got systems that are sending kids on field trips almost daily.
I think perhaps maybe a suggestion would be this. There are many, there are instances, I think, where particularly older children getting into middle school and beyond are managing the disease on their own every day, and a parent could potentially give a written permission to allow the child to go on a field trip. I still think the mandate needs to be there.
Yes.
But in the instance you're talking about, okay, we've got a shortage of personnel, and the option is we're either going to cancel the field trip or not. Maybe we give the parents, and maybe that's something we work on as we head over towards the Senate. As we head over towards the Senate, because I want to think about it a little bit.
I'm fine with that.
But allowing a parent a little bit of discretion there to allow a kid. I would ask the committee to leave it as is now, but it's something I think that's worth discussion.
You know, Madam Chair, when we say parents stepping up, in the real world where they shoot real bullets, if you go to System A and you put those kindergartens and those first graders and you take them to aquariums, you know how many of those great mothers are going to be right there holding their hand? Dozens.
Well, I will tell you.
But I will also tell you, in some of the poorest areas, you're going to look there and you're lucky if you get 2 grandmothers. Well, we've all seen that model too.
And Chairman, Chairman Reinders, I'll tell you this: my wife has been on every single field trip in the last year my daughter has been on, and I think that might be a good change potentially. I want to think about it a little bit and get it right and not do it on the fly today, but that we allow a parent to go with the child, or I think that's something definitely worth doing and looking at.
Thank you. Thank you, Madam Chair.
Okay. All right. Representative Jurgensen?
Thank you, Madam Chair. Since this is an amendment, I guess I'll hold this. And
you ready for the amendments?
Okay. Yes, ma'am.
Let me get a motion on the bill. Okay, I've got a motion to pass. Do I hear a second?
Madam Chair, I think Representative Howard wanted to offer
Oh, sorry.
the motion.
Okay. Representative Howard.
Thank Representative Watson for yielding. I'd like to make a motion to do pass.
Okay, I have a motion to do pass from Representative Howard and a second from Representative Watson. I'm tired today, Representative Howard. I apologize. Okay. Further discussion or amendments? Representative Jurgensen.
Thank you, Madam Chair. And I believe council has the amendment there. Looking at this, I believe we would, anywhere in the bill, strike the words private school and then add subsection G, which would read, a private school which complies with the requirements of this code section shall have the same limited liability for such school and its employees in the same manner as for public schools as provided in subsection F of this code section. And that would go at the end of the bill in the limited liability section.
And what that does, I think that it is going to be in the private schools. I think any private school that has a child with diabetes would be crazy not to avail themselves of this, because the carrot here is the liability hold harmless, plus you get all the resources of this. I think what's going to be a great training protocol that's developed. So I think it sets up an opt-in situation that's not mandatory, that I think makes a lot of sense, and appreciate Betsy's work on the language.
Do we have a copy of the amendment or anything? I can read it again. And this gives them the opt-out?
No, what it effectively is, it removes the mandate for private schools, and what it says is at the end of the bill it adds a section that says effectively private schools, if you comply with this code section, if you go through the training, if you provide the minimum number of trained school personnel, then you get the liability hold harmless. So we're allowing you to go through the training, to have the minimum number of personnel, to keep
Okay, I understand.
Right.
Okay, so what we're doing is just anywhere in the bill that it said eliminates the private schools.
Right, yes ma'am.
Okay, Representative Ramsey, I'm hearing this bill because we're getting late in the days, and I'm going to work with you on this. But the next time you come to health, if you already know that the private schools and people want to opt out, we need to work on that first so we don't get into this kind of situation.
I will tell you, Madam Chair, that this has been discussed even as recently as 5 minutes before the hearing, and it's still an issue that I'm very conflicted about. So I understand.
Okay.
I certainly understand.
Okay, and under that case, because we're getting late, and I know this is very personal, because normally I would say we would hold it to next time, but because of your personal involvement in this, and I know your passion for the subject, I would like, okay, so we have an amendment. Okay, you have a second on the amendment. Any discussion? Everyone in favor of Representative Jurgensen's amendment, say aye. Everyone opposed, no. Okay, the ayes have it. I would like to make an amendment and suggest that on line 59, that would start to read no later than August 1st, 2012, the Department of Education and the Georgia Board of School Nurses. So we would eliminate and the Department of Public Health, this Department of Education, the Department of Public Health. God, we've got everybody in here. I would, right.
We're scratching the Georgia Composite Board, the Georgia,
I think that it would, with the Department of Education, I think we should just leave it with the Department of Education and the Georgia Association of School Nurses and eliminate everything between. So you would, on line 59, you would eliminate at the end, and the Department of Public Health in conjunction with the Georgia Board of Nurses and the Georgia Composite Medical Board. and you would omit all of that. And Betsy, can you read it like it would read? However you want it to read legally. I'd like to make that amendment. Got okay. Second, any discussion? Everyone in favor of the amendment as stated? Anyone opposed? Okay. And also, Representative Ramsey, I would like your commitment that as we go forth, you will look at the fact of maybe some wording that would say maybe 2 in the school nurse, or encourage other people to be more than that, and that you would look at an option for children on school field trips.
Absolutely. We'll continue to be vigilant in looking for solutions to those questions.
Okay. Thank you. And with that, we have on the bill, we have a motion and a second. Everyone in the favor of the passage of the substitute to House Bill 879 as amended, say aye. Anyone opposed, no. The ayes have it, and thank you very much for bringing that one to us. Okay. And I apologize to the people that are here to talk about the defibrillator bill. We will get to it. This one has run longer than usual. Representative Watson, let's see how fast you can get 714 through. Sorry, hang on. No, it's not the one. Watson's is 845. I am really out of it today. House Bill 845.
House Bill 845, the LC 334478. This bill would require child care. In a nutshell, it's educational, encouraging influenza vaccination.
That was quick. Thank you. All right, questions for Representative Watson? Representative Pack.
Dr. Watson, in line 21, I'm wondering what the criminal liability is that we're immunizing for. Pun intended.
Right. This does hold the child care centers, holds them harmless from a civil or criminal liability if they do not do that. You're right. I can't imagine any criminal liability with that.
Okay. Representative Dempsey.
I just wanted to thank Representative Watson for this great piece of legislation, and at the appropriate time, make a motion.
Okay. Do we have other questions? No questions. Representative Dempsey.
Yes, I'd like to make a motion that we do pass.
Okay, we have a motion that we do pass House Bill 845. Do we have a second? Okay, further discussion. Okay, hearing no discussion, everyone in favor of the passage of House Bill 845, say aye.
Aye.
Anyone opposed, no. Sounds like the ayes have it. Thank you very much. And I want to thank the committee for staying with us on this. And once again, I apologize to Representative Amerson for being at the end of the committee, and for the people that are with you for having to wait so long. The problems we are having that have brought this bill about are extremely important and certainly deserve a hearing on it. So, Representative Amerson.
Thank you, Madam Chair. I'll be brief, and then, but this is sort of personal. Mrs. Waring, I've known since she was a little girl, and the substance is that last spring her husband died at a private gym, and they did not have a defibrillator. What this bill would do would require each health club to have a defibrillator, and if you look on page 2, lines 32 through 51 lists the emergency procedures that would be needed. At this time, I would like to call on Ms. Waring. Our expert witness for today is not here, but we do have a letter from him. So Ms. Waring, Ms. Comer, And Mr. Lindsay, if you would come up front.
Coming, if you'll just tell us your name when you're going to speak, and Ms. Waring, I'm very sorry for your loss. And
Thank you, Madam.
I know this is not easy to come and sit here and wait to talk to us.
That's fine. We appreciate the opportunity. I am Heather Waring, widow of Brian Waring. Thank you in advance for your consideration of House Bill 714 in an effort to provide evidence to you as to why I believe this bill should get the opportunity to become a law. I'm going to relay as briefly as I can the events of March 29, 2011 and what happened to my husband. Brian Scott Waring, husband and father of two, put his dog in her crate, dropped his daughter, who had turned 14 the day before, off at school, and proceeded to the gym as he had done countless times before. He arrived at Fitness 19 on McGinnis Ferry Road in Forsyth County shortly before 9 a.m. He began a standard regimen of weightlifting. He was midway through his workout when the absolutely unthinkable happened. Eyewitnesses claimed he pushed himself from the weight bench, bracing one arm on the weight bar while the other hand clutched at his chest. He immediately fell to the floor, hitting his head on the weight bar while falling down. He was writhing on the floor for several seconds before gym members realized he was in cardiac distress. This man was the very picture of health, and he had suffered a cardiac arrest. Effie was the first bystander who rushed to his aid. She determined he was not breathing, ran to the front desk to get help. She didn't know CPR herself. Staff members at the gym rushed to his side. Onlookers began alerting other patrons. Astonishingly to me, none of the Fitness 19 employees who were there were trained in CPR. However, there was a retired nurse along with her husband, a retired EMT, who were present that day. Once they were alerted, almost 3 minutes later, they rushed to his side, and as reported to me by the registered nurse herself, she immediately asked the gym staff for the portable AED, which is the automated external defibrillator. She told me that she sat in stunned silence when she was advised that the gym did not own an AED. She and her husband had been professionally trained in CPR, and they performed the potential life-saving procedure on my husband until the fire department EMTs arrived, almost 10 minutes after the cardiac arrest commenced. Yes, almost 10 minutes after my husband's heart stopped beating, the device that would have almost certainly saved his life was finally present, 10 minutes later. One might be able to appreciate the fact that 10 minutes is a very long time for a cardiac arrest victim to be without 100% oxygen flow to the brain. Unfortunately, my husband had to endure such a scenario. Due to the delay in obtaining proper equipment to restart his heart, i.e. the automatic external defibrillator, my perfectly healthy 40-year-old husband, who was in the prime of his life, was stricken with irreversible brain damage. Consequently, the damage that I and my family have had to endure since the loss of my husband is also irreversible. My husband remained at Emory in ICU in a coma and on life support for the next 12 days. 12 torturous days for his entire family. During this time, Taylor, his 14-year-old daughter, and Austin, his 10-year-old son, and I, his wife of almost 18 years, had to say goodbye to one of the brightest lights this earth has ever seen. This devoted husband, father of two, military veteran, and local EMS helicopter pilot was a tremendous loss to us and those he served. He died because the facility in which he chose to work out in and trusted to have proper safety equipment in all areas failed him on all counts. According to the American Heart Association, a victim's chances of survival are reduced by 7 to 10% with every minute that passes without CPR and defibrillation. If this health facility had made one simple purchase of safety equipment, my husband and my children's father would have likely had a 70% chance of survival rather than the 10% he was afforded because the AED was not present. It was not present in a facility that not only encourages you to exert your body and put your heart under stressful conditions, but it requires a membership to do so. A membership should afford its members some form of basic health precautionary measure such as an AED. There is an expectation that if an emergency occurs, the proper equipment will be available. AEDs are so commonplace that I counted nearly 30 at the Orlando theme parks that my children and I recently visited. They are common sights in airports, shopping malls. They're mandated at high school sporting venues. It's only logical that fitness clubs should be required by law to install and maintain them. Ironically, I've discovered that many gyms in the area already have these devices. So ensuring by law that all exercise facilities have these AEDs is not only a logical step, but one that is highly recommended by the American Heart Association. 11 other states already require this. Dr. Greg Robertson, cardiologist from Emory, could not be here today, but he provided a letter that he requested we hand out, which we did. If there's time, Sherry's going to read it. If not, we're going to go ahead and let Marcus speak. Marcus and Sherry are both co-workers of Brian at Air Methods, and Marcus can actually speak toward the more medical facts.
Okay.
Thank you, Madam Chair, members of the committee, and a special thank you to Representative Amerson for sponsoring this bill. My name is Marcus Lindsay. I'm a flight paramedic with AirLife Georgia, and I have been caring for the ill and injured for a total of 14 years as a firefighter, emergency medical technician, ground-based and flight paramedic. I've witnessed firsthand the profound impact of early recognition and appropriate care of individuals suffering sudden cardiac arrest, and simply put, it saves lives. The American Heart Association is recognized both nationally and internationally as the authority on research and establishment of care standards for heart disease. Much of the information I will share with you today is directly referenced from the AHA's research findings and recommendations. And although I am an AHA certified instructor in 3 disciplines that they sanction, I am in no way here on their behalf. According to the American Heart Association, at least 250,000 Americans die each year of sudden cardiac arrest before ever reaching a hospital. Sudden cardiac arrest does not discriminate. It can happen to, and as evidenced by Brian's case, people of any age or fitness level. Most often, sudden cardiac arrest is caused by an abnormal heart rhythm called ventricular fibrillation, or VFib, many of you have heard of. It's a chaotic disruption in the heart's electrical conduction system, but most importantly, the heart stops pumping blood. This sharp reduction in blood pressure from the lack of a heartbeat will result in the patient immediately losing consciousness. They are clinically dead at this point, but for a few minutes there is still hope. Cardiopulmonary resuscitation, or CPR, can buy us a little time, but the only effective therapy to restore a normal perfusing or pumping heart rhythm is an electrical shock by a defibrillator. It's not like what we see on TV where they pump on their chest for a couple of seconds and the victim wakes up. That simply does not happen. Like Heather said, for each minute that a patient lies or a victim lies pulseless, the chance of survival decreases by 7 to 10%, and that is according to the AHA. The AHA's research has demonstrated that defibrillation is most effective within 3 to 5 minutes of onset of cardiac arrest. 3 to 5 minutes. The only way to effectively provide access to that level of care is to have defibrillation capabilities on site, and the way to ensure this is through an AED, or automated external defibrillator. These devices are designed for use by the lay public, and many of us are familiar with them, for they have been around for several years. In just 4 hours or less, anyone can be trained and certified to use an AED. It is known by most that regular exercise promotes good health. But it's also recognized by the American Heart Association that the incidence of sudden cardiac arrest increases during strenuous exercise. This increased workload on the heart can be the tipping point for an individual with some underlying and often undiagnosed heart abnormality or disease. It is for these reasons that we must ensure that trained personnel and the right equipment are available at all times at fitness facilities or any facility where the purpose of operation is exercise and improving physical fitness. The good news is once a facility makes the decision to implement an AED program, most of the work has been done for them. A wealth of information can be found on the AHA website, and that is AmericanHeart.org. They have a simple guide to the implementation of an AED program. With regards to liability, Georgia has what most common folks know as Good Samaritan laws in place to provide protection to civilians providing care to those in need. And you have this in your handout, a copy of the official Code of Georgia annotated, section 51-1-29.3. I'd be happy to recite that, but you have that in your packet in front of you as well. The cost involved for the equipment is usually less than that of a gym quality treadmill, and in most cases less than the flat screen TVs mounted on the wall. In some cases, in many cases, and I've done this myself, training can be provided free of charge by local organizations and outreach programs. It is clear that the benefits of mandating the presence of functioning automated external defibrillators and trained personnel at fitness facilities far outweigh the associated cost. The information, again, to establish such a program is readily available by the American Heart Association. As stated in the research data that I've previously mentioned, the ratification of this measure will save lives. I urge you to pass this bill and ultimately make it a law. Thank you very much.
Do you have anything you'd like to add to that, or Ms. Cohen?
Well, you have the letter. You have the letter from the cardiologist that took care of Brian in front of you. I'd be happy to go through that if you'd like. The only other thing that I would like to state that as a nurse of 15 years, who I've worked ER, ICU, CCU, I've worked in the coronary cath lab, and I've also been a flight nurse for the past 6 years. I 100% support this bill and can't even begin to tell you that Marcus and I have been partners together on the helicopter, and Brian was our pilot. And I can't begin to tell you how sad and frustrating it was to us to see him lying in the hospital, knowing that had the appropriate equipment been present at this gym, he'd still be out there saving lives today by flying these patients to the places that they need to be in the Atlanta area. And I'd just like to say I support this bill.
Any questions for the presenters? You've got one, Representative Tokus.
Thank you. I appreciate y'all bringing that to our attention. I've got a question, and maybe y'all may be able to answer that. Is this being done in other states?
Yes, sir. I know for a fact at least 11 states it is law that fitness facilities require such equipment and training.
Thank you.
Representative Kaiser.
Thank you, Madam Chairwoman. I have two specific questions. One is, could you talk specifically to the cost of it? And then I guess this would be for the author. Would the health club, would that include, the terminology include like YMCAs, and is there any limitation on the number of, like if it's a little small health facility, is there any limitation on the size of it that would be required to have one of these?
Well, it shouldn't if it's a health facility.
Not as written in the bill, but I have recommendations from the physical therapy people in Augusta that they say with all clubs with under 5,000 clients should have one. If they go over 5,000, then you have multiple. But that's not in the bill.
Okay. Representative Jervis, Representative Kaiser, you through? Sure.
I would just like to add to what Representative Amerson was saying, a little bit of an answer to your question. Just in some of my research, some other states required all, according to what I read, all fitness facilities to have this equipment and training. Others made some limited exceptions for personal training facilities where it's more like one-on-one personal trainer to client. In some cases, I think those might have been exempt. but overwhelmingly, most of what we know as a commercial gym for membership, all of those in those at least 11 states, it's required. And as to the cost of the equipment, most AEDs are between $1,200 and $2,000.
Couldn't be too much, Representative Kaiser. The OBGYNs gave me one for my office upstairs, so it's
Wonderful.
right. If you have something happen on the 4th floor, it's in my office.
Real quick, just on the size of the fitness centers, it's my hope, and I believe that's the way the bill was written, that all fitness centers, regardless of size, would have at least one with trained personnel, because the gym that my husband was at was it was a smaller gym. I mean, it is a national chain, but it was a smaller gym membership. So, it would be my hope that at least one would be required on site. That's all that would have been needed to save his life.
Representative Jurgensen.
Thank you, Madam Chair. And ma'am, thank you for being here. My certain condolences to you. And Representative Amerson, I have some questions for you, technical questions from the bill standpoint. I understand from your testimony today that you're trying to target health care, or health facilities, gyms, and that type of thing. Representative, the way that I'm reading this bill, I'm afraid that, and correct me if I'm wrong, but starting in section 1 there on line 22,
Representative Jurgensen, I don't want to cut you off, but this is a hearing only today. Okay, but anything that you can work out or talk to him about later, that's okay. I mean, if you feel like if you feel like it needs to be today, go ahead.
Well, I'll just be real quick. On line 24, the term well-being, it says development of physical fitness or well-being. I don't know that well-being is defined anywhere in the law. And I'm sitting here kind of thinking through what are other types of facilities, because it says in line 23, services or facilities. What other types of facilities would these might be? Would it be a place where somebody does yoga or does massage therapy, or these things that aren't gyms but would fall under this definition? And it may or may not be your intention to include those places, but I think this is a very wide-reaching definition of those types of facilities, and it may or may not be what you're targeting there.
You're absolutely right, because we did exclude hotels, motels, and people with workout centers. But I'm not a lawyer either, so I explained the situation to our legal counsel, and this is what he came up with.
Okay. Thank you.
That it? Okay. Representative Pack.
Thank you, Madam Chairwoman. I know it's been a long day. The question I had from a factual standpoint, I'm terribly sorry for your loss. As I read the bill, and I'm trying to get background on the other states that actually enacted something like this. As I read this, as long as you have a machine on premises, but there's no obligation to actually use it after the training. So how did the other states kind of address that? Because we're kind of assuming that the employees or the expected users, since there's a AED machine on the premises, that they're going to use it. But there's nothing that imposes that duty on the employees to actually use it.
Representative Pack, it does, in fact, because if you look on page 2, there are a set of emergency procedures laid out starting at line 32. Each health club shall, goes through there.
Okay, it says to go through training.
Yep.
It says to notify the appropriate emergency medical services system. It says ensure that the machines are functioning, and then ensure that there's an involvement of licensed physicians. But there's no duty on the employees to actually use the machine on the person that's needed. Right. Which obviously is a big issue. Okay. And I am an attorney, and one thing I see here is if you read to the section that's not impacted by here, the immunity, I think the intent is to force people to actually act, and by having the machines, you're granting blanket immunity to the premises owners and their employees. So I don't know if that's what was designed in the other states, or if that's something that we want to try to address. And I know it's hearing only, Madam Chairwoman, but it was an interest. I just had that question.
Okay, and that's a very good point, Representative Pack. Dr. Watson, have you got a pressing?
Well, I just may be able to clarify that. You know, you guys remember this. I mean, this dates back. You know, AEDs date back. I think probably 2 decades. You know, Washington State, I think, was the first one in the U.S. to do that. And these were bystanders using AEDs, and that's what most of the time, you know, like your husband's situation, that a bystander would have been using that. I mean, they're simple. You've been trained on it, and I mean, they usually follow directions. And I would. These are generally in airports. It's not necessarily trained in my health at this Sheraton. I mean, we have an AED there. There's nobody trained there. It's going to be a bystander to use these mostly.
Right. They give you step-by-step instructions when you do it, and will not shock a person if they do not need it. So Representative Watson is correct on that. But if we move forward with the bill, I think it could be more specific, Representative Pack, if you could just make it clear. Representative Drenner. I can't talk today.
Drenner. Rhymes with winner.
I don't know how my... Apparently, Carla, my knee is affecting my head, my hurt knee. Go ahead.
My arm is affecting my body as well.
Okay.
So much for physical fitness. Mr. Chairman, my only offered suggestion is when I did a bill similar regarding tanning beds here, one of the groups that came to talk to me at length was these 24-hour fitness facilities where there is not an attendant on duty after hours. And so I would just offer that somewhere in the bill that some mention of those particular facilities be clear, spelled out in terms of how exactly it's going to be applicable to them.
Okay.
That's just my suggestion.
Thank you.
Where there are no attendants.
Where there's no attendance.
Oh, no, there she is. Representative Henson.
Thank you. Going back to lines 22 in Health Club, is this a definition that's currently in law? A definition that's currently in law. On line 22, it says health club means any
Commercial establishment.
So we're in fact establishing or setting forth a definition for what a health club is. But won't it be used elsewhere? Because now we have defined health clubs. Okay. Thank you.
Okay. Are there other questions for Representative Amos, Chairman Amos? No. Okay. In that case, we have other defibrillator bills that have come forth from other problems that have arisen. So, as I said, this was a hearing only. Thank you, Representative Amos, for bringing it into the committee, for staying and listening to it. Once again, we're sorry for your loss. Thank you for the testimony that certainly brings it home to all of us, to any of us. This could happen to a spouse or a child. I think one of the most famous ones that happened last year was one of the Kennedy daughters. Kara died suddenly in the gym. So I think it is something that we really need to look at, and I really appreciate you being willing to come, and especially to you and to the members of the committee. You are the best for hanging in there with us this long. Thank you again. And we are adjourned.